مرة تانية الحقيقة بشكر كل القائمين على المؤتمر، أساتذتنا في قسم الباطنة، وبشكر أبوت إن هم ادوني فرصة إن أنا أتكلم على موضوع مش عارف أقول عليه شيق ولا قديم ولا جديد. It's very hard to talk about IBS، مرض العصر وكل عصر. دي أول حاجة جت في بالي لما قلت أتكلم على IBS. النولج كتيرة جدا جدا، الإكسبيرينسز بتاعتنا مختلفة، لكن this is how to approach إنه all the knowledge we have about IBS لازم تبقى formulated in an approach. And before the approach, let's go basic. IBS, by definition, is a gastrointestinal syndrome characterized by chronic abdominal pain, وده الهولمارك of the disease, and unaltered bowel habits, whether constipation, diarrhea, or alternating. Disease ليه burden كبير جدا، لأنه disease منتشر جدا. It affects between 3 to 22% of persons worldwide. Only about 50% of those patients can actually seek help through a GP حتى، مش بس gastroenterology. 30% medical help, and the cost في أمريكا مثلا $8 billion per year spent related to IBS. So very high economic burden. About 70% are women, and 50% develop symptoms prior to the age of 35, 20% between ages 35 and 50, although I would be very reluctant to diagnose a patient with IBS at age 50. Psychiatric illness frequently accompanies it, but no clear causal link has been established. وده اللي كتير مننا يعني في معتقد ثابت انه psychosomatic disorder. I cannot agree 100%. I cannot disagree 100%. فأنا فاكر أول ما بدأت my own private practice I was aware of المشكلة دي، وعايز أعرف فعلا الريليشن. IBS affects the quality of life greatly. For 50 days per year missing work, that's a lot, and 30% of patients with IBS miss work days. Economic burden. There is no clear etiology, as we said, altered GI motility, GI hypersensitivity, psychological factors, family factors, food intolerance, inflammation, and stress related. So the theory of post-infectious hypothesis is the one mostly practiced or mostly thought of, يعني almost established, and there is some sort of infection that has started and triggered a cascade of inflammation. Many factors integrated together are the cause of IBS, so we cannot say that only one factor, like the psychological, but also there is a little bit of altered motility causing the distension, the spasm, and visceral hypersensitivity as well. So there is a clear interrelation between factors. So is it truly psychological? I started my practice and I was very eager to know. فكان في وقت كده 8-10 سنين عجاف للزمالك، فكنت دايما بقول للبيشنت انت اهلاوي ولا زملكاوي عشان اطلع برسنتج.
انت زملكاوي دكتور حسام ولا اهلاوي؟
طب جاسر النمبرز تبقى عامله ازاي؟ جاس النمبرز هتبقى عامله ازاي في ال10 سنين دول؟ Only 12% كانوا أهلاوية and 88% من IBS patients كانوا زملكاوية. فأنا إيه بقى؟ أهلاوي. أنا أهلاوي صريح. Okay. Diagnosis the old-fashioned way. Listening to the patient, taking very good history. In history, you can diagnose patients just by history, I guess, in about 75% of cases. So taking good history, listening very well, the mainstay of the diagnosis. And if you want a guideline, it would be something like the Gastroenterology Association, American Gastroenterology Association, where it says diagnosis of IBS should be based upon the identification of positive symptoms. That's very important. Identification of possible symptoms consistent with the condition and excluding in a cost-effective manner, of course, other conditions with similar clinical presentations. Abdominal pain is the hallmark with whatever, you name it, bloating, distension, altered bowel habits, constipation, diarrhea. But you must have pain. Basic labs to do, our basic investigations are important, at least to identify the red flags, and then you can be able by then to classify the IBS. And the most common IBS is the one with alternating bowel habits, not diarrhea, not constipation. And there is a stool form that you can, you have to talk to the patient, ask about his stool form, because this would help you classify the disease. And this was not left so subjective like it looks here. Bristol score, Bristol stool scale was a more objective approach to diagnose the types or differentiate between the types of IBS, because this will be reflected on therapy. Of course, we cannot disregard Rome criteria, and the most accepted criteria to diagnose a very subjective disease like IBS. Originally created in 1992 وشهدت تعديلات كثيرة جدا up to Rome 4. أول واحدة خالص كانت بتتكلم per month 12 months إنه يبقى فيه 12 weeks or more out of 12 months. البيشنت عنده symptom والsymptom must include abdominal pain. Plus minus بقى relief identification associated with change in stool, associated with a change in stool form or appearance. المهم إن يكون عنده pain plus 2 of the others. رجعت الروم كرايتيريا غيرت شويه وقالت بدل ما نحسب بالسنه كام اسبوع في السنه، لا احنا بنتكلم على abdominal pain و discomfort at least 3 days per month. فقللت المده شويه عشان اقدر communicate this to my patients. وبعد كده خففت تاني، بقت الروم كرايتيريا بتتكلم على 1 day per week. لو البيشنت تعبان 1 day per week عنده abdominal pain plus بقى 2 من الثلاثه دول related to defecation associated with change in the frequency أو the form or appearance of the stool, this is IBS. More important than diagnosing IBS is the red flags. لأنه السهل الممتنع IBS في دكاترة كتير خصوصا GPs. IBS is a very rapid diagnosis. يعني انت عندك قولون عصبي وبيخبي وراه بلاوي. So at least revise the red flags. If any of those red flags is present, this warrants meticulous investigation. Okay. So establishing diagnosis is by very wordy criteria, whether Rome criteria or American gastroenterology. A lot of talking with the patient, that's very important. And differential diagnosis, I want to just to point to the lactose intolerance. In my practice, and I don't know if you have the same feeling, in my practice, many of the patients who are diagnosed IBS are actually lactose intolerant. ولما بيبطلوا الميلك they feel a lot better. So the therapeutic approach is first establishing an empathetic relationship with the patient. This is not always right in all cases, but in cases of IBS, this is the first and foremost approach is to establish an empathetic relation with the patient, make him understand that you feel for him and you can feel his pain, and yes, he has a problem, he is not crazy. Identifying associated factors and treat them, whether the patient is stressed, anxiety, depression, whatever. So this is also a lot of talking to identify associated factors. And the dietary recommendations الdietary recommendations في IBS are not so easy. Then there is no one size fits all في dietary recommendations. And if you want to go objective ويبقى FODMAP, it's quite difficult for us. I believe you must involve a nutritionist. Having said that, and perhaps also a psychologist or a psychiatrist, best treatment of IBS is actually multidisciplinary. Pain management, which is very important for the patient. We have a lot to give to the patient. Ticagrelor خلاص طبعا obsolete. Up to tricyclic antidepressants. But the most important antispasmodics are ones like the clidinium, البراكس اللي كنا بنستخدمه كتير جدا, and of course the mebiverine. The mebiverine cornerstone في التريتمنت. mebiverine of course بتاع Abbott. Mebiverine is a musculotropic antispasmodic with a direct effect on the smooth muscle of the gastrointestinal tract, and it relieves spasm without affecting normal gut motility. So perhaps this is the most important point that I personally like about using mebiverine, because it gives a direct effect not mediated by the autonomic nervous system. The typical anticholinergic side effects are absent if used with the recommended doses. So how does mebiverine work? It's all about preventing and closing the calcium channel. If you close the calcium channel, there will be no reflux of calcium, and accordingly, there will be no spasms. So, mebiverine works by closing the calcium channels. It improved diarrhea, constipation in IBS patients with some validation in some literature. And the quality of life in patients with IBS is much improved with the mebiverine, but give in the right doses and for the right time. Many of us start changing treatment to the patient in less than 2 weeks. That's not enough. For IBS, we're talking about 8 weeks minimum عشان نشوف effect. Right dosing is very important. عشان كده الميبيفرين 200 is taken twice, whereas others اللي فيهم suboptimal dose they have to be taken 3 times عشان يوصل ل 400 ملغ per day. So, mebiverine, I guess we all know it is effective and also safe. Proven safety profile over a long term, يعني من بداية ال 1960s وفي research بيتعمل على الميبيفرين, and we could not see major side effects from the mebiverine. Okay, still with the pain management, we can also use tricyclic antidepressants, and I use very limited 1 or 2 drugs that I know, and then otherwise I have a psychiatrist that should be involved in the treatment of patients. As for IBS with diarrhea predominant type, there are some, of course, different approaches in treatment. أهمهم is to stop the diarrhea. Loperamide can be used for that sake, and also cholestyramine and antibiotics. For IBS دي بيبقى الثيري اللي قلنا عليها ان it started post-infectious coming more to light, so we use antibiotic. Rifaximin was found to be one of the best antibiotics used for this case, but please use the full dose. 550 milligrams every 8 hours. لأنه كتير مننا بيستخدم a much lower dose, and this is not recommended. For IBS constipation, it's all about bowel movement. So you should push for bowel movement as much as you can, avoiding lactulose عشان gas distension. I will have to run. Antibiotics, as we said, is now much more accepted than before, especially in IBS, the diarrhea predominant type. Probiotics, في literature كتير جدا ممكن اطلعه بيقول البروبيوتكس هايله وفي ليترشر كتير جدا جدا ممكن تطلع يقول البروبايوتكس مالهاش اي رول، فاحنا لسه في الحته بتاعت الجراي زون. So using probiotics, it's up to you. It's the art of medicine, not the science of medicine. For the science, I can't give you enough data. بس from my personal experience انا شفت ان البروبايوتكس بيحسنوا حاجتين، البلوتنج والديستنشن والجاس، اكتر حاجه بيحسنوها. It is not a surprise to say in IBS is a chronic disease, and chronic disease there is no treatment but there is management. Only 5% ممكن يبطلوا التريتمنت ويخفوا، فده رقم مخيف جدا. Only 5% and 95% will turn into chronic. Again, use your experience and knowledge wisely. Thank you.